Hello and welcome, everyone. We're so glad to see you here. I'm Ronnie Snyder, president of the John A. Hartford Foundation, and I want to thank you for joining this briefing about the opportunity to transform care for rural older adults through the Rural Health Transformation Program. We at the John A. Hartford Foundation are a nonpartisan national philanthropy working to improve the care of older adults. So we don't lobby, but we do seek to educate policymakers and other people about how their decisions impact older people and family caregiving. The foundation and our network of grantees work really hard to expand the availability of high quality, age-friendly care and increase support for family caregivers all throughout the US. And that's especially in rural areas where access can be particularly difficult. There's been enormous interest in this briefing, so we're really pleased you're here. Before we begin, I want to provide a little bit of context for today's briefing. Like our national population, our rural population is aging. So nearly 85% of the country's older age counties, which are counties that have more than 1 in 5 people who are age 65 or older, are rural themselves. As all of us age, we have the opportunity to make really vital contributions to our families and our communities. And sometimes we may require support for that, but the lower an area's proportion of working age adult, the fewer people available to provide care to older people or pay the taxes to fund the programs that help us to age in place. This is especially challenging for rural older adults who are even more likely to live with complex health challenges associated with chronic conditions, maybe experience functional limitations, rely on Medicaid and Medicare, and face barriers that are related to things like transportation and social isolation and food insecurity, as well as accessing specialized care and increasing rates of hospital closures in our rural areas. Given that older people have health needs and reliance on publicly funded programs, improving care and outcomes can then have a really significant effect on federal, state, and local budgets. Age-friendly care, which we promote and think about all day, every day, professionally speaking, including the reliable delivery of evidence-based practices based on a 4M's framework, which is what matters to older people and their caregivers, medications, mind, anything cognitive, and mobility is one solution. Today, we have the opportunity to spread age-friendly care for older people presented by the Rural Health Transformation Program. So that program is a $50 billion federal fund authorized by H.R. 1, which is also called the One Big Beautiful Bill Act, to improve rural healthcare access, as well as quality and outcomes all across the country. So while rural providers and hospitals are going to face some fairly daunting challenges in overcoming H.R. 1's Medicaid cuts, the Rural Health Transformation Program does give us some opportunity to weave age-friendly care into the fabric of those rural communities. And we believe that will be a win for older people in all of our communities. It's coordinated by the Centers for Medicare and Medicaid Services, CMS, and the fund itself is intended to support programs that address those systemic issues and improve access to care while bringing in new innovative work. All 50 states applied, and all 50 states received funding from the $50 billion program. And that funding itself is scheduled to be released through 2030. Still, there are many, many questions about the process, next steps, who's responsible for what, and the truth is a lot of those answers are not immediately clear. So that's why we're here today. We've brought together some speakers who can talk from their own experience with the Rural Health Transformation Program from very different vantage points. We hope that this kind of sharing can ultimately help answer some questions and really, ideally, even spark some new ideas for you and for the rest of our audience. You're going to hear suggested next steps from advocates, for community-based organizations, for regulators, and for state and federal policymakers. I'm really looking forward to this. We've got a great lineup. So with that, I'm going to introduce our 3 speakers. First of all, Alan Morgan is the CEO of the National Rural Health Association. They're a grantee of ours. Alan's a fantastic speaker. You're in for a treat. NRHA, as it's called, is a membership organization advancing rural health improvement through advocacy, communications, education, and research. Next up, we will have Julie Foster Hagen, who is the executive director of the Office of Rural Health Transformation and Sustainability. She's got it all, transformation and sustainability, at the Louisiana Department of Health. That is the office that's using the Rural Health Transformation Program funds to drive transformative change for rural people who are in Louisiana. And then we get to hear from Dr. Elizabeth Foster. She is the clinical policy advisor at Connected Care for Older Adults in Oregon. That is a really innovative program that improves care for older people in rural Oregon by empowering CHWs, community health workers, to deliver age-friendly care based on the 4Ms that I just referenced. So before I turn it over to Alan, I do want to invite you to submit any questions you've got for our panelists using Zoom's Q&A feature at the bottom of your window. And while you're thinking about that and finding that feature, I want to toss it over to Alan. Alan, will you start off by telling us a little bit more about the Rural Health Transformation Plan?
Absolutely. Ronnie, I appreciate the opportunity to join you today and talk about my favorite topic, which is rural health and rural populations. Next slide, please. Oh, there we go. Great. So I'm with the National Rural Health Association. As Ronnie indicated, it's a membership organization. If you care about rural America, there's a home for you in the NRHA. Simply Google, Yahoo, Bing, rural health, and NRHA is going to be one of the first 5 responses that comes up. We're closely tracking the Rural Transformation Program and also closely tracking its potential benefit and impact on older Americans as well, too. Next slide, please. You know, Ronnie indicated at the very beginning that rural is a unique healthcare delivery environment. It's not a small version of urban. It's a place where those most in need of healthcare services oftentimes have the fewest options available. It's a population which has a higher percentage of elderly, higher percentage of low income, and higher percentage of those who have higher health needs. So that's not a great marketing message for those trying to move to rural America, but it accurately describes the challenge. Now, the good thing about that is these challenges drive innovation. And that's one thing I hope you keep in mind throughout this presentation today. The key messages of innovation and sustainability, which they are going to be a paramount moving forward. Ronnie mentioned that this unique program was included within H.R. 1, the One Big Beautiful Bill, $50 billion, which is a recognition of the Medicaid cuts. But I need to be clear and dispel a myth. This is specifically in both the legislation, the regulation, and the grant promulgation, not intended to offset Medicaid cuts. Instead, it is a once-in-a-lifetime opportunity to redesign the healthcare system in rural America with an eye towards sustainability. Next slide, please. So Ronnie also indicated not every state received the same amount of funding for this. Last fall, each state applied for this grant and laid out, sometimes in great specificity, sometimes fairly general, what they intended to do with their allotment. And they were awarded grants based on their application. Since that time, the states have been awarded the applications, and now we're working closely with CMS on developing the details of these programs. It's important to note these grants to each state are different in each state, number one. 2, this is what's known as a cooperative agreement, which means it's a partnership between the federal government and the states going ahead. So at the end of this first year, there is the option that the federal government may pull back some funding for particular states and provide additional funding for other states based on the performance of this. That's the reason why this concept of innovation, sustainability, and also tracking outcomes becomes so very important as we move forward. Next slide, please. Now, you're going to hear today and throughout the course of the upcoming months about the overall goals of this particular program. And you see these strategic goals here. I'm not going to read them to you. Instead, I'm going to highlight some specific areas underneath there where they're going to see actual impact when it comes to the lives and health of older Americans. Most notably, when we talk about workforce in rural America, many states are including tools to help older adults access health services and information. That's going to be tremendously helpful. Utilizing technology to support tools to help older adults access health services and information as well too. You're going to see provisions and programs to address evidence-based programs that help older adults live healthier, more independent lives in rural settings. And of course, one thing that we're particularly excited about is this concept of building regional care models or hubs that will connect aging services and home and community-based care, chronic care management, and care coordination as we move forward. Next slide, please. So in specific, each state has a different approach to this. Again, I want to go back to my website. Our team is tracking this as it moves forward. We have a guide which lists out each state and what they're doing, in particular, not just for older adults, but for all of healthcare. It's a great ongoing resource so you can see what your state is doing compared to the other states. Next resource. Next slide, please. So overall, looking at the rural component of it, we see 16 state applications which specifically indicate a rural healthy aging program included within their grant application. And one state in particular, Pennsylvania, has listed it as a primary initiative. Now, I want to be clear about this. These are states that have actually called out programs for older Americans within this grant application. But that does not mean that not every state is going to have programs impacting in a positive manner older adults. I want to emphasize that. I think this is one thing that is going to permeate each state's application and grant process going forward. I've listed in this slide, pulled out some of the specific initiatives that we're hearing from the states. I'm not going to read those to you. You'll hear some of those in specific from the presenters later on today. Next slide, please. Now, as you may know, the federal government is big, and in any large organization, you have great employees and you have employees that are not so good. I want to indicate, and I want to make sure that I'm clear at this point, that the Office of Rural Health Transformation in CMS, they are stacked with incredible professionals who know healthcare, know rural, understand rural healthcare, and are deeply committed to this. I'm saying this to you right now that in some grant programs you're checking boxes. This is not one that you're going to be checking boxes in. This is one that you're going to want to be able to show outcomes, sustainability, and again, every program in here has to have a transformation component to it. This is not just keeping the doors open on rural facilities, but in actually redesigning how we do healthcare as we move forward on this. It's going to be so very important as we move forward that this transformation is front and center. Next slide, please. Okay, so going ahead, you're going to hear now specifically from individuals talking about what's happening in the states, but I want to circle back to the component that this is a generational opportunity to transform with a sustainability lens in mind, how we deliver healthcare in a rural context. So with that, Ronnie, I'll kick it back to you.
Thanks, Alan. That was great. And you know, through the partnership that we have with NRHA, with your peers at your organization, we've seen the creativity of state offices of rural health in spreading age-friendly health systems, you know, forums, care, but also just in working for and around aging broadly. A couple of specific states come to mind, like Nebraska and New York, but there are many more. And I loved a couple of the points that you made. I'm going to put an exclamation point on them. That slide that you put up with the strategic goals, there were 5 columns that talked about things like workforce and access and health IT. They are not aging specific, but aging can be, should be, really must be a through line through all of those for a state to be well considering their rural populations for all the reasons that you just referenced. Thank you so much. Before we move to our next speaker, I want to remind everybody to please share any questions you might have using the Zoom Q&A feature. And then I'm going to go to our next speaker. So let's hear from Julie Foster Hagen to talk about what the Rural Health Transformation Program process has been like in practice and where things stand now for her. Julie?
Thank you. Yeah, so I am Julie Foster Hagen. I have been with the department for over 27 years and worked really primarily in the disability arena. And they asked me to stay on and help write this grant because in Louisiana, we really do see this as encompassing all populations in rural health, all regardless of who your insurer is. So we didn't see it as a Medicaid program or a Medicare program, but really thinking about all of our different insurers, all of our different healthcare partners, and all of the different parts of the agency. And so I'm excited to help lead in Louisiana, sort of where we were to get to our grant and now where we're going in the future. So I'll take you a little bit through our journey, sort of as we thought about it from the point of application to really what we see for the future. Okay, next slide. So once we found out about the opportunity when the One Big Beautiful Bill Act came, for states, we had a pretty short window of time to actually write a very large application. So Alan shared some of us were able to get into a lot of details, some maybe not so much. In Louisiana, we really do value stakeholder engagement and feedback. And so we immediately started thinking about how do we make as many opportunities as possible to hear from people so we can make sure that the things we include in our application really are reflective of what the needs of our rural communities are in Louisiana. We all opened up an opportunity for folks to apply through a request for information. We did hear many we did have many requests to consider the elderly population, the aging population in our state, and the particular needs that they may have. Some of those really were embedded, as we'll talk about in some other initiatives, but we did hear a lot of feedback from them. We also held community idea raisers where we went into different parts of the state in rural communities so that we had an opportunity to hear from people living there, provider agencies, other folks that are involved in healthcare, so that we could hear their voice. And again, what rose to the top was more encouragement or more information around the needs to really consider our aging rural population. We also had put together a 64-member task force that did include various members that were, your traditional folks inside of healthcare, but we did have folks from the Home Health Association and our nursing home associations who were part of our task force and part of that. So we made sure that there was a voice there specific to our aging population. That task force really helped us to take the information that we learned from our request for information from our community idea raisers and really pull it into our initiatives and strategies that landed in our application. We also did a lot of data analysis. So Alan mentioned a lot of data in the very beginning, and so, we did take a look at that in our before writing our grant application. Some of that information is in our grant in our grant, and it really helped for us to identify where are the gaps, where do we need to address it from the data perspective. And we looked at that really by community. Individual rural communities look different, even across Louisiana, but also by population. So we did some population specific information. And then we spent a lot of time navigating the federal guidance. So there, again, we had a short window and there was a lot of information in the notice of funding opportunity, as well as a lot of frequently asked questions and things that we needed to get us to the point of application. Okay. And so states did have the ability to decide, sorry, next slide. They had the ability to decide which of those strategies that Alan mentioned at the beginning would make their way into the application. We had to do at least 3 areas in Louisiana because of the input that we had. We chose to have initiatives and strategies across all of them. We did land on, initiatives in all of the areas. we ended up with 20 different funding strategies. And so that will be a lot for us to navigate. And we realized that, but we really wanted to be forward thinking and be able to really start to address the needs. Some of the areas where we definitely see involvement, as has been mentioned, you know, while we do have one specific to the aging population, we do consider that the different populations of disability and aging will be considered in a lot of our different strategies. You know, with workforce, especially, we know that there will be some targeted needs to think about workforce as it pertains to specific healthcare needs of our aging population. We do plan to have a lot of engagement with our community colleges as well as our universities across the state to look at how we begin to really expand that. We also plan to do a lot around technology innovations. There's a lot of great information out there that we do think will have a significant impact on our aging population around remote patient monitoring and remote monitoring devices. Especially for our aging population with chronic disease. You know, we hear a lot about people living in rural areas having to go you know, an hour or two to get to a specialist. Well, what are some things we can do other than, you know, addressing transportation needs? We can start to look at technology and how we get that care closer to where people live. But we also, because we know sometimes technology can be a little scary for folks, we did build in digital literacy or health technology, digital literacy, so that we can start to use some community health workers or other types of navigators to help people understand the technology and use it. So many of our strategies, there's 20 strategies, but they all really kind of overlap with each other. And then lastly, we did have a specific initiatives around expanding our PACE sites. In Louisiana, we have a lot of great outcomes that we've been able to show with the PACE entities that we have, but we haven't seen a lot of expansion, and there's lots of different reasons. That could be probably a whole webinar in and of itself. But what we do know is that there are no opportunities for PACE in our rural communities. Folks would have to travel very far to be able to engage in that. So we specifically looked at opportunities that would help with what we heard is that there's startup cost to be able to get out there. There's considerations that need to be given where you might not have as many people going to PACE, where we need to think about what that billing metric is. So we will be looking at startup as well as expansion and what needs to happen to make sure our rural residents have access to that valuable resource. All right, next slide. So once we did get the approval from CMS, and it was a great announcement that we got the money, and then we said, but what we had to do then is spend the next several weeks really working through coming into compliance and giving CMS enough information so that those funds could be unrestricted and start to draw down. So for states, we've been actively involved in a lot of the logistics up to this point. So we've updated our budget and budget narratives primarily. We have had to be responsive to CMS and to make sure in the grant, there are certain clarifications of what the money can be used for, what it can't be used for, what those caps are. So there's been a lot of negotiation between CMS and states on making sure that we are in compliance with what the actions that we're taking. And then really planning to move forward for implementation. There's a small window of time for us in the first year to get these funds out before we have to start giving reports to find out what we're getting in those next years. And so we've really been focused as states on those logistics and on making sure that we're thinking about that. I do envision, and this may be getting a little bit into future, what you'll see is in the out years, you're going to really start to see states be able to really start thinking about that population integration, especially our older rural citizens, and how we do that. Up to this point, it's been hard for us to focus on those more specific granular details as we, again, continue to work through all of the logistics. We've also been really focused on outreach and making sure our communities are aware of the opportunity and what's coming up. Although sometimes that does, there's a lot of interest, as we said at the top of this. And so sometimes navigating all of the interest can be a little bit challenging. All right, next slide. So we do see in our future that we actually in Louisiana are combining all of our state rural health grants into one office. So there are a lot of opportunities through your state offices of rural health in states. And we envision this working collaboratively with those other grants that are really kind of in a different area, but HRSA, so that we can start to complement each other. As Ellen said, there's a huge focus on sustainability. So we also are pulling in our Medicaid partners and all partners we have so that as we look at this, not just, and we intentionally put the word sustainability in our office name so that we're focusing on that from the very beginning. We do want to continue to build our internal and external relationships. In Louisiana, we have a group called the Live at Home Coalition that is very involved in helping people be able to be supported at home if that's the option that they choose. And they are very much at the table and part of our discussions as we look to move this towards implementation. And then we also will continue, CMS has clearly let us know this is going to be a partnership. So we'll continue to navigate the additional guidance that's coming out as we look forward towards implementation. Next slide. All right, so some things that we learned is that when we talk about our rural communities, we need to really make sure that we're building trust. So and understanding their needs. So we don't envision our role being to sit in our capital office and make mandates, but we intend for our new office to be out and about in rural communities, hearing from them as we roll these strategies out. We need to know from them, are things working or not working? We also, as I said, will begin really diving into what are the specific population needs that we have and how might we need to tweak our designs over time, while trying to be innovative, but also balancing fiscal responsibility. We do know that there's a need to be good stewards of these funds. It is a lot of money. It's a very large grant. So we're balancing innovation and fiscal responsibility. And again, just our partnerships and relationships are going to be vital for us being able to show success now and in the future. And again, the final lesson I'll chat on is just the sustainability. We're embedding that from the very beginning. We do not want this to be like what happens with so many grants where we hear, we did this really great thing for 5 years and then the money went away and now we don't do that great thing anymore. But how do we make sure that the information that we're sharing and the programs and the activities we're funding have long-term sustainability? All right, I do believe there's just one more Stevens amendment in here that lets you know that this is Julie's comments. These did not come from CMS and that we did, from Louisiana's perspective, receive the $208.3 million, which is what I'm speaking on. All right, thank you.
Perfect, Julie. Thank you so much. That is a lot of logistics and coordination embedded in all the things that you just said. So I can kind of feel the weight of that. And I want to draw out a couple of quick comments about things that you said. So first of all, you referenced all parts of the population. And then you also referenced at the beginning of your comments requests to consider older people. And so I just want to note, for us, this is a yes and, right? There are things that are specifically focused on aging. And you said you've got one of those. I assume it was your PACE expansion, the alternative sites.
Yes.
And then the ways, as I mentioned before, to sort of see that through line. I think it's fantastic. And I loved the lived experience you referenced by going out to the community. And that included both older adults themselves, but also the facilities that serve them, the kinds of places where any of us will find ourselves in rural communities as we age. Thank you for that. Okay, I'm really happy to see so many good questions coming in from the audience. A reminder that we're going to turn to those after our next speaker. So please go ahead and send your questions in using that Zoom Q&A feature. And then last but not least, I love this program so much. Dr. Foster, will you tell us about connected care for older adults?
I'm really pleased to have the opportunity to talk about connected care for older adults. This program was designed by rural clinicians who were concerned about their fragile rural older adult patients who might put their best foot forward in the exam room at an office visit, but don't have the support they need to stay safely in their homes. Next slide, please. In connected care, community health workers conduct a series of home visits where they implement protocols based on the 4Ms of age-friendly care. These CHWs are embedded in primary care clinics. They chart directly in the electronic medical record, and they route important information and actions needed directly back to the patient's clinician. Our CHWs provide patients and families with information and education, system navigation, advocacy, and connect them with existing community resources. This is a short-term support. Patients move through the program usually within 90 days. Next slide, please. So we've talked about age-friendly care already. You're probably familiar with it. It is recommended for all older adults, and it's evidence-based. That means it's effective and it works. And this forms the basis for our CHW home visits. Next slide, please. Since our pilot first launched in late 2022, Connected Care has been implemented in 7 rural clinics in Oregon and is currently active in 5. Our program was named in Oregon's Rural Health Transformation Program application, and we're exploring opportunities through the RHTP to expand Connected Care to other rural clinics in the state. Next slide. To date, 86 clinicians have referred their older patients that they're most worried about, reaching over 500 patients. It's notable that over 95% of the patients are covered by public payers, Medicare, Medicaid, or both. On average, our patients receive 4 to 5 home visits and up to 10 or more care coordination calls. And I am especially proud that our community health workers have been able to double the number of patients who have an advance directive. And new data I'm sharing for the first time today show meaningful decreases in high cost utilization. And what's more, over 95% of the patients and clinicians surveyed said they were very satisfied with the program. Next slide, please. Clinicians have been overwhelmingly pleased with the program reaching patients they were concerned about, prioritizing what matters to a patient, seeing what is actually going on in their home, and identifying and addressing barriers can markedly improve clinical care. One clinician states, "I absolutely want to see this program thrive and grow in order to increase access to services for some of our most vulnerable patients. I love it." Next slide. Patients that we've surveyed almost universally appreciate the attention, coordination, and support to meet their needs. One patient said, "It helps us understand what will be needed in the future, what to plan for." Next slide. Data show promising reductions in high cost utilization. This chart shows monthly rates of hospitalization and emergency room visits, which you can see on the left were increasing prior to the program and decreased during and after the program. Next slide, please. Here's a story about a connected care patient. We'll call her Denise. Denise is an older patient who had repeated gaps in her medical care. She has severe depression that interfered with regular clinic visits. She was unhoused for a period of time. After months of being out of touch with her clinic, she would return with a long list of concerns or with issues that were addressed previously but didn't get timely follow-through. Thus, processes had to be started all over again with little progress made to improve her health. Rosa, in the center, is the CHW working with this patient. She's been with us for 2 years now, and she has made some miracles happen. She connected Denise with housing services, got her broken glasses repaired, helped get her scheduled for dental care, and completed intake forms that are necessary to be able to access additional services. She even helped her complete a recommended sleep study, which identified severe sleep apnea. Most importantly, Rosa helped Denise establish regular care with the county's mental health provider so she could get treatment for the depression that had hindered her care for so long. This story was shared with us by Denise's primary care clinician, who said she's now coming to appointments and we're able to work through the steps to promote her health and well-being. I would not have been able to do this myself without the help of Connected Care. Next slide, please. What are we learning? Through this pilot effort, we're learning that Connected Care is a promising model for improving primary care services for older adults in rural settings. For less than $2,000 per patient, it makes meaningful impacts on quality of care and cost-saving measures. We're excited to explore opportunities through the Rural Health Transformation Program to scale this model to rural clinics across the state. Next slide, please. Despite the success of Connected Care, we've encountered a number of challenges. The most important challenge is to recognize the resource constraints, both financial and human, facing our rural clinics and our critical access hospitals. These are lean operations. Asking them to implement new programs to do even more is going to continue to be a significant challenge. Sustainable, viable payment mechanisms that adequately compensate rural clinics for the true cost of delivering this level of care are lacking. What does exist is limited and prohibitively burdensome or inaccessible for the rural clinics that we've partnered with. Travel time and mileage to reach patients in their homes are not currently covered by CMS billing codes. Next slide, please. Keys to our success. First and foremost, we've centered the need of rural clinicians, clinics, and patients in the design and implementation of this model. We have streamlined administrative processes and requirements and built in flexibility so that the program can adapt to the unique requirements of each individual clinic. We've invested in evaluation from the beginning and invited feedback from all members of the team to improve our work. We've also built educational and peer support structures for the CHW workforce. We heard early on that programs that come and go in a single year are not only unhelpful to rural clinics, but can actually cause damage to trust and partnerships and can simply burn out clinical staff. So it is important to allow for and fund the time it really takes for rural clinics to try new things. Innovation takes time, so be patient and keep at it. Next slide, please. Finally, we've had some truly incredible partners who have supported our work, and we're grateful for their expertise, support, and investment. And we are also, all of us on the webinar today, deeply indebted to the John A. Hartford Foundation for all of their leadership in the care of older adults, as well as their contribution of age-friendly care. Next slide. Thank you very much.
Thank you so much, Dr. Foster. Gosh, and I'm really glad that you brought a story so we could see sort of a face to go with that. I love the quote that she made miracles happen. We know that community health workers do a lot of different things in a lot of different communities, and we really just love and appreciate the way that you've deployed them in Oregon. We are doing some work with NRHA, which was, I believe, represented with the logo that you had on a previous slide. This also around community health workers and building the partnerships between what you're doing and what they're doing and what other communities are doing, I think are so important to the sustainability and the replication of really good work like this. Okay, let's go to some questions. You can submit yours using that Q&A feature on the Zoom screen. Before we go to the audience questions, I would like to start with one of my own, if I may. Alan, NRHA has had a lot of contact with federal government agencies and with the CMS office itself that's overseeing the Rural Health Transformation Program. Have you got any news or updates that you can share with us about the program?
What a great question to start with. Well, we are waiting with bated breath on additional guidance that's supposed to be coming out to all 50 states. And I'll have to turn to Julie later on to see if she's actually received that guidance or not, to give a little bit more clarification going ahead. But to that point, Ronnie, I do want to two things in particular. One, thank you for mentioning our age-friendly effort, rural age-friendly effort that we're engaged with you on. And again, for all the listeners, know that we have compiled a compendium of best practices on our website as well, too. So if you're thinking about getting engaged, it's a great opportunity to look at what has already worked and see if you can fit into replicating that, number one. Number two, which this should have been mentioned up front, and that is, in your state. Not all states have a Julie who is overseeing a office of transformation, but every state has a state office of rural health. Great opportunity. Please reach out to your state office of rural health, ask how you can get involved and how your initiative within your rural community can fit into this overall practice.
Love it. Every state needs a Julie. All right, one way or another, wherever they are. Speaking of Julie, my next question is for you, Julie. How did CMS's spending directives and limitations affect how states thought about their approaches? So, for example, are there changes you'd like to see in the program's spending guardrails as it continues into its second year and then beyond?
Yeah, so I don't know that they were limiting, initially. I think that from the state perspective, there's still a lot of questions that we have as we're continuing to work through that. And I think that that was what Alan was referencing. I think that's probably the biggest guidance that we're waiting on. It is some different, and we didn't get that. We did have our first kind of the kickoff Rural Health Summit. That was a summit that CMS put on last week in Baltimore that all states participated in. And so we had a lot of really great discussion and conversation with our project officers and some of the leadership at CMS as well. But I think that will continue to grow. What I really like about this opportunity with CMS is that all the collaboration that we are able to have with our project officers. So we have questions. For example, our state was one of, I think there's only 7 or 8 who chose to do investments in the Tech Catalyst Fund. And we still have some questions in terms of what the guardrails are or are not around that Tech Catalyst Fund, which means that there can be investments that would potentially have longer term impacts around technology. But exactly how you handle investments using government funds is sort of still in question for us. So I would envision that over time, we'll learn more about, kind of where those guardrails are. The other thing that's, I think, interesting is CMS is really encouraging us to learn from each other. And so while our applications are our applications for the 5 years, so they can't change much from what we have in there, it sounds like we will have the opportunity to really take a look at the data and the spending. So maybe we decided, I'll use our own PACE example. Maybe we decided and based our number on the fact that we'd be able to expand 2 or 3 PACE sites per year. And if we're not able to see that uptake, then doesn't mean we give up. It means that we think, well, why aren't we? And what might we need to do differently to encourage the care that people need? And so I think that there's guardrails, but I do think as we all learn together, there'll continue to be ongoing guidance. It's not just going to be a one and done, but an ongoing learning process through the entire grant period.
That would be a fantastic way to capitalize on the word innovation that is used to describe these funds. Thank you. That's great. Dr. Foster, we're going right in a row, apparently. The next question is for you, and I'm really glad because I saw so much sort of excited, enthusiastic chatter as you were speaking about the CHW work that you're doing and about CHWs in general. So the question for you is, are there ways that connected care approaches billing to increase the likelihood of long-time viability separate from RHTP funding, given what a great case you made for the fact that we need continued investment and we need sustained investment?
That's a great question. We're working on this on 3 fronts. First, we're working with clinics to develop simplified clinical pathways that allow them to access complex billing mechanisms that can partially cover the cost of their CHW workforce. Second, we're evaluating our program to demonstrate outcomes that can be helpful to meet targets in alternative payment models and ACOs. And importantly, these outcomes also achieve cost savings that we believe will help reduce the cost of care for this patient population, saving taxpayer money. Finally, we're working with national partners and with our legislators to lobby for changes in rules that will adequately compensate clinics for this work and allow transportation for home visits in rural areas to be included as a reimbursable activity.
Great. Anything you can do to show cost savings? We know not just this administration, but all administrations of recent past have been very much cued into that. So great points. Thank you. Okay, so we're getting a lot of questions right now about the role of the Aging Services Network, something we think about a lot. So this is for any of you. How can area agencies on aging and community-based organizations be involved in this work?
Let me quickly jump into that one because I love that one. The answer is yes, yes, and yes. The key aspect of this, and I said it right from the beginning, is this is not a tool to keep the doors of rural hospitals open, but it is a tool to prompt collaboration across sector. I cannot emphasize that enough. You need to be looking at area agencies on aging. You need to be looking at Meals on Wheels, the clinics, the community health centers, the hospitals. How do you bring everyone together? And those are going to be the successful applications for the grants at the state level, and really going to be the ones that you're going to see the innovative approaches for sustainability.
Love that. Anybody else want to add on to that?
I'll jump in. Just so I can tell you from the summit, one of the things that states are really thinking about, and I mentioned outreach a few times in ours, but we did all talk about what is our plan to have ongoing engagement with communities, or how do we make sure that our populations, all interested parties are understanding and knowing what's going on. We've all set up governance structures. Each one of us does have a plan. It looks a little different. But for example, in Louisiana, we'll establish an advisory council. And so I would say encourage folks that are looking at advocacy, find out from your state. And all states should at this point have at least an email or a website or some way that you can reach out to the entity that's over the rural health transformation program and find out what are their opportunities for public meetings or advisory councils, so that you can make sure that your voice is heard. Because I do know that all states, again, it'll be set up a little bit different, but all states are planning to have those opportunities to hear from the communities in different ways.
That's great. Dr. Foster, I thought I saw you come off of mute before. I'm going to give you a second if you want.
Well, I just think the area agencies on aging are critical. I mean, they hold the resources that community health workers help connect patients with. So really, we're outreach workers for the area agencies on aging.
Love it. Okay, so we're talking about statewide plans, and we're talking specifically about rural health here today. You know, there are these state multi-sector plans on aging, or master plans on aging, depending on what a given state calls it. And so one of the questions we have is around how could the Rural Health Transformation Program intersect with those state multi-sector plans on aging to make sure that we're fully building in the resources with the need to grow cross-sector?
So I'll jump in first on that. So in Louisiana, we probably are a little unique. So where the grant fell in Louisiana is under our Louisiana Department of Health umbrella. That umbrella, we're in the midst of our budget process. And so having to explain our budget, it's as big as the budget of some small countries, is what one of the legislators just said. But under our umbrella, we have our Office of Aging and Adult Services, Citizens with Developmental Disabilities, Behavioral Health, Medicaid agency, public health agency, as well as our licensing agency. So we are also looking at policies that might need to change as a result of this. And so for us, that multi-sector plan falls under our Office of Aging and Adult Services with input from the others. And so there at the table, we're building internal working groups where we're pulling those folks together as we start to dive into those different populations and considerations, whether that's population health, whether that's older Americans, whether that's people with disabilities. And so I do think that there's opportunities. For us, it's a little bit easier for us to be at the table because our secretary expects enterprise thinking and for all of us to talk to each other. But if not, from a state perspective, then making sure you know who those partners are and working. Because this grant went from the governor's office, I do think that all states are having at least some expectation that our state agencies work together. So reinforcing that would be helpful.
That's great. Anybody else want to take a stab at that one?
I'm just going to build upon what Julie said. It's nothing like funding to force collaboration, and both in the community level, but also within the state government level. So I don't see anything but good things coming out of this.
That's great. You know, I talked earlier about aging being a through line really through the Rural Health Transformation Program. And I think that it's a similar concept with regard to the multi-sector plans. Rural has got to be a through line as well. They build into each other. It's not one direction. It's very much bi-directional.
Gosh, Ronnie, thank you for saying that. Our membership includes doctors, clinicians, state employees, and aging issues and the concerns of older Americans is a cross-sector approach that just permeates all the work that we do. And I think you're seeing that not just from the discussion today, but also the questions that are coming through the chat.
Perfect. Thank you. Well, I got a new one for you all. The next question. Can funds be used to expand adult day services? Like funds are being used in some states, such as Louisiana, for PACE. Can they also be used for adult day services? And do we know, I guess, if there are any states that are specifically doing that?
So I can't speak to whether there are states who are, Ellen may know that one more from having dug into the applications, but there's not specifics around the types of facilities that we are able to do. They just need to be in rural areas. And be able to support rural communities. And there's even some flexibility when you're talking about mobile clinics, right? So the mobile clinic might originate in an urban area, but go into the rural areas. And so states have given us, in my opinion, CMS has given states a lot of flexibility in allowing us to really define that and describe that. They did have, types of facilities in the notice of funding opportunity that kind of focus more on your CCBHCs and your rural health clinics and your FQHCs, but it didn't say only, so I do think that there's nothing that would prohibit us from considering anything that is supporting our rural communities based on a need that we have there. No guidance that I've seen that would prohibit that.
That's fantastic. Okay. As we come to a close, we're getting near the end of our time. I want to invite each one of the speakers, each one of you, to reflect in a minute or less. It's very top line. What's the one takeaway that you want to leave our audience with today to help ensure that rural older adults get age-friendly care through the Rural Health Transformation Program and other initiatives?
Well, let me start because I think I have the easiest message, and that is make your voice heard. That is so key. Voice heard for innovation and sustainability. That's an easy takeaway for this. Get involved, contact the State Office of Rural Health. If you have a State Rural Health Association, get involved with that as well too, and reach out and make sure that your input is happening.
Love it.
I would actually echo what Alan said. A lot of times folks feel like, oh no, you're so busy. I don't want to bother you. And it's really not a bother. It's important that we hear your voice. The only thing I would add to that is that I just would ask folks to be patient with states. As I mentioned, we're all working through lots of logistics. And so don't feel like if you don't get an immediate response that your voice is not being heard, or that, be persistent in sharing that voice, and know that there are some things that we're having to be focused on right now, but that we absolutely want to have an opportunity to hear from you, and your voice will help us figure out the direction that we need to go to and where things are working and not working throughout this process.
Fantastic. Last but not least.
Well, I think I would address comments to states and local organizations, and I would say, learn about how community health workers are being used in your community today, and think about what role they might play in transforming your rural health system. For policymakers, I would urge you to streamline reporting requirements and billing requirements. For example, all of the RHTP reporting requirements placed on participating states are then passed on to projects and to clinics that are trying to do the work. And quarterly financial and activity reports ultimately take time away from clinical care. So I think we just want to do effective work, do what we need, but streamline it wherever possible.
Those are all great. Get involved. We want to hear your voice. Be patient and persistent. I think it's not one or the other. It's another both and, right? Not one or the other. And learn about community health workers and streamline reporting requirements. I think those are all fantastic recommendations for those who are in our audience and learning about both what's happening and what the opportunities will be. And I will mine would really be, make sure you're thinking about aging, both as its own topic and sort of the lifespan approach, because it's where we all are headed. It's where we all want to be. And making sure that our older adults in all of our communities are best cared for and supported is what's really critical for our younger generations as well. As we end, I want to thank you, Alan, Julie, Elizabeth, for your time, for your insights, and absolutely for offering us your expertise. And I want to thank everybody who joined us today. We are so grateful for your interest and your participation. I saw some things in the chat about a recording of the event, and there will be, so that will be available, and links to the resources as well will be emailed to everyone and made available at johnahartford.org. We would love it if you would complete a brief survey about the event. It helps us do better each time, and the link is in the chat. And all of us at the John A. Hartford Foundation are available to be a resource to you whenever, wherever possible. Since we operate nationally, I often say wherever you are, we are too. And then, I just want to end on this point. We collectively can work to improve the care of older people and create a more age-friendly society for everyone, regardless of where each of us live. Thank you so much.